Hello, everybody, and welcome to the bi-monthly webinar of the Geriatric ED Collaborative. Thanks for joining us. As people are rolling in, we'll get started. My name is Don Milady. I'm the moderator of this webinar. I'm an emergency physician at Mount Sinai Hospital in Toronto, Canada. I'm a core faculty member with the Geriatric Emergency Department Collaborative. And we're continuing this series of webinars. It's been now running for 2.5 years about various ways that you can make improvements in your emergency department to improve the care of older people. Wherever we originally had planned a webinar exclusively about the accreditation process, but a few weeks ago, as the emergency department and healthcare changed throughout the world, we thought we would shift focus a little bit. Wherever you are calling in from, United States, Canada, or anywhere else in the world, probably you're in the middle of some kind of Omicron or COVID-related mess, disaster, as everything seems to just be getting worse. So everybody's impacted badly by COVID and have been for the last 2 years. I think many of us would claim that the group of people who have been impacted perhaps the worst are older people, both those living in communities and especially those coming to emergency departments for our care and the care we provide there. They continue to be present in our emergency departments, and it's easy to lose sight of how serious their care needs are and how we really need to do something different to provide the excellent care that they deserve. However, or perhaps because of that, because of all the challenges that we're facing, a lot of emergency departments are really doing great work to make sure that they're delivering excellent care. So instead of focusing on just all the problems that COVID is presenting to us, we really wanted to shine a highlight on emergency departments, in this case around the United States, but smaller places, larger places, rural, urban, community, academic sites that have really stepped up to the challenge of COVID for older people in emergency departments. So we're giving an opportunity to a larger panel than usual to share tips, tricks, and as we said, strategies for coping in this very difficult time. And I also really need to send a huge shout out to all of us, all of those folks, wherever you are working at the moment. We're doing our best. We're all working hard. It's a challenging time, and I personally am very grateful to everybody who's doing what they can, and I know that our patients who are the beneficiaries of that care are very grateful too. On a next slide, please. So I think you're familiar with the Geriatric ED Collaborative. Our vision is there. We see a world where all emergency departments provide high quality care for older people. If you share that vision, please join us. Institutions and individual emergency departments can become members, and we'll post the link for that into the chat. You can go to our website, which is cited there, and go to the partnerships section to find out what we offer and how you can come to benefit from it. Today's webinar is being recorded and will be up on the website within a few days, both the slides, the recording, and some notes to accompany it. So if you know people in your department who are interested, please pass that on to them. We would like to express our appreciation to our two principal funders, the John A. Hartford Foundation and the West Health Institute. They've been our partners throughout the last 6 years, and we couldn't do this work without their support. Next slide. So this is the topic for today's presentation, how to continue providing excellent geriatric ED care during time of COVID. And we're going to hear strategies for coping with that. Next slide. We've got a larger panel than usual because there are so many good ideas and opportunities for ways that we can improve. I'm going to introduce everybody now, and then we will hear from them sequentially over the next few minutes. Aaron Malsch is a nurse and a geriatric ED program manager for the senior services for the Advocate Aurora system. That's a large healthcare system based in Wisconsin and Illinois. His two colleagues, both called Amber, leading me to assume that everyone in Washington County, Wisconsin, is called Amber, since 100% of the people I know are called Amber. Amber Koplitz is the manager of emergency services. She's the nurse manager there. And her colleague, Amber Widenski, is an emergency physician and the medical director and the geriatric ED lead for the same system. As you'll hear, that hospital is a smaller hospital located in a smaller town, and we're really interested to hear how they've been successful. Nida Degyses is an emergency physician and the director of the age-friendly emergency department at the University of California, San Francisco. That is the most recently accredited level 1 geriatric emergency department, a task they accomplished completely during COVID. Pam Martin is my colleague as one of the core faculty with the Geriatric ED Collaborative. Pam is a nurse and a geriatric nurse specialist with the Yale New Haven Health system in Connecticut. And her colleague, and our colleague on the GEDC, is Ula Hwang. Ula is in fact the principal investigator for the GEDC. She's a professor of emergency medicine, vice chair for research at Yale School of Medicine, and a leading figure in geriatric emergency medicine. And both Lauren Southerland and Katie Buck are emergency physicians at Ohio State University. Lauren was the founder of the geriatric emergency department there, currently the director of clinical research. And Katie Buck is her more than ample successor as the director of their geriatric emergency department programs. And next slide. So this is really, we're hoping to channel the wisdom of the crowd. There's a lot of people. Currently, we're up to almost 95 people on the call from around the world. We are interested in knowing what kinds of things you're succeeding with. So if you could take a moment to go to chat, switch the default over to everyone, so your message goes out to everyone. And if you can think of just one innovation, or maybe not innovation, just some good practice that you are doing at your site that has an impact on older adults during the pandemic, we would really appreciate hearing about that. So I'm just going to take a little pause here so that you can send out the good stuff that you're doing at your place. I'm just taking a moment to check out some of the things that people are chatting in. So right down to some sort of basic clinical changes like finding a way to administer monoclonal antibodies to geriatric patients, adding case management. We'll have a chance to revisit some of those things, and maybe our panelists will be able to comment on them as well. And then finally, just before we get started, and as you're finishing up with that, we're also always interested to know where you're calling in from and what your role is. So if you can take a moment also to text in where you're working and what your role is there. Okay, so I think we can go to full screen at this point and see everybody's happy faces. I'm going to start with the Ambers of Hartford, Wisconsin. So, as I understand, you'll tell us a bit more. You work in a relatively small hospital, but your manager, Aaron Malsch, we invited you specifically because he had such great things to say about what you have managed to accomplish and maintain during COVID. So Amber Koplitz, can you start off and just tell us some of the things that you're doing and that you're particularly proud of?
Sure, yeah, definitely. So thank you so much. We really have focused here with our increased volume. We've seen about a 50% increase in our volume, patient volume per day. And we have really significantly reduced our ED bounce backs and our readmissions. And that has come from a really great collaboration with social work and home health. So the ED physicians, under the guidance from Dr. Widenski, have really started to work collaboratively with placing service 2 orders for home health. And what we have found is those patients are then receiving those cares outside in the community. So then they do not have to return to the emergency department to receive any additional care or be readmitted.
Amber, can you just describe like what kind of services they would be able to receive in your community and how that gets set up?
Sure. So we currently can write orders for like home oxygen if they're COVID positive. That was part of Medicare and Medicaid lifting that. Along with physical therapy or nursing, they can go into the home and then see that. And it's a really great collaboration between the physicians in the emergency department along with the primary care physicians. We are a small community hospital, so there are those conversations happening frequently between those two collaboratives, where if we can take that load off of the primary care physician, that they don't have to see the patient and follow up a week later, the physician will just write that order in the emergency department and we can get started ahead of time.
And who are the conversations happening between, and how do you make sure that they happen?
Yeah, they really do happen with social works involved, the primary care physicians. They are either talking on the phone or through secure chat, like through our Epic EHR. So they are having those conversations, or in person. Many times these physicians are rounding in the hospital because these are their patients that are admitted. So they come on in and they see their own patients.
And Dawn, when I put the order in for home health, again, like Amber said, I can select it specifically for home health care with physical therapy or with nursing care or any DME. And then I also put it as from the primary care provider. So we're very lucky that most of our patients do have primary care providers in our community. And so I put that order in not as an order from myself per se, but linked to the primary care provider, so that then all follow-up questions regarding the therapy they needs goes to the primary care provider. When I do that, I generally will also send an inbox message to that primary care provider saying, hey, I saw Sally in the ED and this is what happened, so that there's close follow-up there.
So what did it take to get all of that set up, or is that just part of the way things happen in Hartford, Wisconsin?
It took a lot of work. And like I said, it's under Dr. Widenski's great leadership and collaboration with her physicians. Our CMO also sits on our team. And so she she helps to lead that team as well. But Dr. Widenski, anything else to add?
Yeah, I mean, we just have really, so the executives we're all very close. We're all very, friends. We see each other on a day-to-day basis. So the CMO of our hospital is also the lead of what we call our AIMS group, but essentially our hospitalist group, which is not just true hospitalists, there are primary care providers in the clinic. And so we just have that close relationship. I can text or email or call Dr. Lethan, who's our CMO, at any time, but we all sit on the committee for geriatric ED. We all collaborate in that way. And so she's bringing that information back to her team. I'm bringing it to my team. And that way we're all on the same page with our goals. Her and I are both very competitive and we like to be the best. All of us at Hartford like to be the best. And so we really stay on top of our teams in terms of constantly reminding them to be placing these orders, thinking of these options for our patients.
Mm-hmm. So just to provide a little bit of context, Amber Widenski, what numbers are we talking about? Like how big is how many beds in the department? How many visits a day? Even with your big
So we have nine beds in our department. Our averages pre-COVID used to be around, correct me if I'm wrong, Amber, 26, and now we're seeing up into the 30s and 40s daily. Our percentage of geriatric patients, I'm not sure, Amber or Aaron, you may know that.
Right, yeah, it's right under 36, it's like 35.8% of our patients are geriatric.
Mm-hmm. We see a lot of them for falls. A lot of them do still come from nursing homes, but a lot of them come from home in our community.
Amber Widenski, what would you say is your main message when you're talking to your doctors and nurses, the ones who are actually on the front line?
Yeah, so we're really reminding them about the resources we have and our goal of, because we are so small, because our resources are limited, we're always reminding them, let's do everything we can to try to keep our patients who are part of our community safe and at home, not repeating their visits to the ED. And so that means not only putting in these home health referrals that we're talking about, but maybe having physical therapy, see them as a consult before they go home, sending that message, or just making that phone call to their primary before they go home so that we're all on the same page where, is home health the right thing for them, or should we admit them overnight? So really using all of our resources, pharmacy, PT, the primary care, all of that.
Mm-hmm. And Amber Koplitz, just as we're finishing up, can you think of any challenges, but especially how have you overcome those challenges and turned them into successes?
I really think COVID has limited a lot, obviously, with the visitors and with family. And we just stay focused on having that communication with family. And if we do need to, for a moment, bring someone in for teaching so then they can see your family member, yes, they are walking adequately, or this is how we're going to teach them to use a walker, then we definitely bring them in for that moment to make sure that is what's safest for them. So even though we have the limitations, we definitely do what's right.
Mm-hmm. So it certainly sounds like the smallness or the smallness of your site and the kind of community feel that you have helps a lot of these things happen. Do you have any advice for a larger center of key messages that you think are part of your communication?
I think it's just really important to always share the success stories. Many times nurses, techs, physicians are saying, why am I doing this again? It's definitely to bring that story back and say, remember this patient, this is why we do this. And we post a lot of our statistics for our ISAR scores, our comment rates, our service to orders, because that does drive the competition. Along with the physicians, I have several nurses who want to never have a fallout. So they definitely want to see those stats as well.
So stories and statistics. So make sure you're feeding back to the people at the front line what successes come from their actions, and then a little bit of healthy competition fueled by some statistics never hurts. Thanks. Feel free to chime in as we go along to larger centers, Amber and Amber. Aaron, you kind of oversee the whole Advocate Aurora system across big places and other small places. What do you have to add to all of that?
Yeah, I think it comes down to two definite aspects. One is the leadership that Amber and Dr. Widenski have demonstrated, as well as that team, and as well as that sense of community. These are friends and family, and that kind of approach really pays dividends, because I get to work with 18 different teams throughout our system. So I get to see a wide range of experiences, especially over this last 2 years. And the leadership that definitely these two have demonstrated is really exceptional. When you consider that 50% increase in volumes, the staffing issues, the issues with boarding patients in the ED, while at the same time maintaining all their key metrics, which is phenomenal, as well as they fast-tracked physical therapy coming down to do consults in the ED, which has led to a great decrease for those patients. So it's really a family approach, a sense of mission, as well as when they're dealing with under these unprecedented conditions. So it comes to that leadership and that sense of community.
And I think you mentioned that there are real values for everyone, patients, but also the system. 30-day return visits have changed.
Yes, and that's been significant, especially as Dr. Widenski said, fallers are the #1 diagnosis for older adult visitors. And to see close to a 40% drop in their 30-day revisits for patients that come in with a fall under these conditions is quite significant. And I think that kind of pays dividends downstream, because as we're dealing with overcrowding, any ways that we can reduce that pressure on our staff and on our EDs it pays great dividends.
Mm-hmm. Good. Okay, thanks a lot. So we're going to move now to the far west coast from small town Wisconsin. Nida, Dr. Degyses at University of California, San Francisco, you succeeded in having your age-friendly emergency department accredited at level 1, which is a very high standard, and you managed to do that all during COVID. You're the medical director there. So we're interested to know what you're doing and how you managed to pull off that accomplishment at this time.
Don, you're so right. So we were able to do all of this like amazing work under perhaps like the worst possible time of anyone's career in life, right? The pandemic. But I actually think it's because the pandemic and COVID actually helped us. And that sounds really crazy, but are you not sick of COVID? Right? I think we're all so sick and tired of COVID and only dealing with COVID, and this person's hypoxic, let's admit them for COVID, and COVID, that I think everyone was really dying to do something meaningful that had very little to do with COVID. And so in our institution, 30 to 35% of our patient volume is over than the age of 65. So we have a huge vulnerable population. And I think we were providing nursing staff and our staff and our providers, both from the medical providers, but PT providers, social work, pharmacy, an opportunity to really improve the care of this vulnerable population that was outside what they were hearing about in the news all the time. So I actually think COVID really helped us. I would be remiss to say that, this was a emergency department only thing. I get to be here as the representative of the AFED, but honestly, our AFED is this huge interdisciplinary team. And I know both Ambers had kind of touched to this, like, team is essential. This team is essential. We have geriatricians as part of our team, social work, pharmacy. We have dedicated AFED pharmacists, a dedicated AFED social worker, and nursing care, and advanced practice providers, that without this huge team working diligently for this patient population, this would have never happened, even before COVID times. So team is really, really critical. But I think in this case, it was really, really helpful in terms of having this happen during COVID.
Mm-hmm. Were there any particular challenges, and how did you overcome them?
Yeah, I think we were able to do, I think we were able to do some really interesting things specifically that were helpful during COVID and challenges that we were able to overcome. One challenge that I've actually been hearing in the chat is this idea of visitation policies during COVID. And so from our perspective, it was actually quite simple, hard, but a simple solution, which is caregivers are not visitors, right? They are essential providers for that family member. And we very early on recognized that. And we were able to change our visitor policy in the emergency department to allow for essential visitors, including caregivers. And that's huge. We all know that this vulnerable patient population needs additional help, right? You're less likely to have a fall if you have a caregiver at bedside. You're more likely to understand your discharge paperwork if you have a caregiver at bedside. You're more likely to actually be able to get really good data if that person's in person. Yes, we're able to call and get additional information from caregivers on the phone, but we found that it was really critical to have this person inpatient, like on site. And honestly, the best way that we were able to do that, because I know it's really hard in other institutions, was you give a story of bad outcomes when the patient doesn't have a caregiver, right? And that's what happened in our institution. One bad outcome, bad story, and how a caregiver could have completely turned that around. And I think that's something that narrative is really, really powerful, better than statistics, quite honestly. And then something that I think that so that I call as like the one simple thing that we did during COVID, but has a huge and meaningful impact, to something that is, I think, a lot harder, but very important to people who make decisions in your institution. And that's this idea of sustainability, right? All of our hospitals, at least mine, talk about how much money they've lost during COVID. And so these programs can be expensive, or they seem expensive on the front end, right? We're hiring a social worker, we're hiring a pharmacist. We have nursing that has dedicated hours to doing screenings and assessments. In our institution, we found that developing a really sustainable, model long-term will help alleviate and offset some of these costs. So the one thing that we're doing, and that has been really great, and we're not there yet. I want to be clear, like we've started this, but not yet. We're not there yet. But we have developed this a model where we have advanced practice providers who are specialized in geriatric assessments, housed in our department of geriatrics. So again, this team idea of working with our geriatricians, one of which I know is on this call, Dr. Todd James, who's amazing. These advanced practice providers are providing this comprehensive geriatric assessment on these patients, and that is billable, right? We bill for orthopedic consults, we bill for neuro consults, you bill for a neurosurgical consult, et cetera. We bill for a geriatrics or a GEDI in our institution consult. And they come in and they are able to provide this comprehensive assessment, do various different screenings, and provide a really good discharge or admission plan, depending. And those are billable. And we've been able to now start actually getting revenue from that. Now, I'm not saying that that's going to completely offset the costs, right? So this is part of it. You're showing the institution, you're showing your C-suite that you are able to generate some revenue. So you offset the costs. And then when you include things like decreased length of stay, if a patient is hospitalized, decreased 30-day readmission rates, et cetera, you can show that the program that you have is really, really valuable and will be able to continue long-term after, if you have funding or not funding. So I think that's the harder thing that we've been able to show, or that we're starting to be able to show.
Mm-hmm. Yeah, sort of a longer term benefit as well.
Exactly.
If folks are interested in a little bit more information on that, back in May or June, we did a really terrific webinar, I think, on making the financial case for a geriatric ED. Laura or Lorraine, if you could maybe post the link. It's available on the GEDC website under the on-demand webinars. But if you're interested in buffing up those arguments about how you can pitch geriatric ED change as a financially valuable thing, not just the right thing to do, but a financially valuable thing or a sustainable thing to do, you might find some arguments there as well. Thanks, Lorraine. And any comments finally, Nida, before we go to the other coast?
Honestly, I think at the end of the day, I can't put enough emphasis on team. These programs cannot work in isolation in the silo of just the emergency department. This is an interdisciplinary team that requires buy-in from everyone.
Mhm.
And we're very lucky to have that.
Yeah, and just as a message, like University of California at San Francisco, Parnassus is obviously generously supported with a lot of resources that many small places don't have. But like a team can also just mean two people. So the Ambers of Hartford, Connecticut is the beginning of a team. And I think within accreditation, that's one of the reasons that the first two things are an MD champion and a nurse champion, because you need to kind of get more than one person interested in this, and eventually you will find partners. So starting to build the team is kind of an essential part of making Geri ED change. Thanks a lot, Nida, and continue to post comments as you wish. Going to the other coast now in Connecticut, we have both Pam Martin, who's a geriatric ED nurse specialist, and Ula Hwang, the queen of all things geriatric ED. So Pam, can you tell us about, you've managed to almost complete the process of getting all of the multiple sites within your system accredited, which means adding a lot of stuff also during COVID. Tell us about what you're doing and how you're doing it.
Thanks, Don. Yeah, Dr. Hwang and I both are pretty new to the Yale New Haven health system. Dr. Hwang came in the summer of 2020 and I came in March of 2021. So both during COVID. I kind of spent my first probably 6 months, like kind of just learning what the system already has, researching what's already going on in the system, found out that we actually have a level 2 geriatric accredited ER right down the street at Bridgeport Hospital. So connected with them, reviewing their protocols and processes that they use for their application. Met with their GEMS providers. They have APRNs in their emergency department. So met with them, shadowed them, kind of just figuring out what's already going on here in New Haven and surrounding area. Started setting up monthly meetings with them. Dr. Hwang and I worked through the geriatrics department. So the three of us started having, weekly meetings, we call them our strategic geriatric ED meetings. And so we meet weekly, just kind of keeping up on the progress of what we found that's happening in the different silos within the Yale New Haven health system. The other thing that we did was we started to add in other members of our team, just as the Ambers and Nida said, having a team and, starting with your ED leadership, nursing and physicians, then moving into your care managers, your social workers, your pharmacy, until you have that team for your local system. Then we started to bridge out into our other hospital systems. So now we have monthly meetings with our entire hospital system on geriatric emergency departments. We also decided that we would focus on one initiative. So we chose delirium. Delirium, works right into what's happening with COVID, as it is sometimes the only symptom that older adults are having when they come into our emergency department. So as we're doing our education, we can, let our staff know that's why we're doing this. That's why we're doing delirium, and that's why we're making changes during COVID, because it is pertinent to the care of our older adults. We also found out that our system was developing care signature pathways for all the hospitals. So we kind of connected with the leaders on that to see how we could create a care signature pathway for ED. So it would be ED specific and geriatric specific for delirium. And so we were able to get that implemented as well during COVID. And now that's the initiative that all of their hospitals will be using for their level 3 accreditation. One of the other things that we did was with their nursing education and our staff, as we're doing our education, we were able to actually be able to pull statistics on which nurses were 100% compliant. So periodically we will reward nurses, and it's always a competition between nurses. If one gets something, the other one wants to know, well, why didn't I get that? Or how do I get that the next time? So, and it's just little prizes. Like right now we're doing rock candy, saying you're a rock star with their geriatric emergency department, with your geriatric emergency department care. So just little things to recognize the staff for the work that they're doing. Also, we send out, lots of education newsletters. Dr. Hwang does education often in the physician leadership realm. So those are some of the things that we have done to make it successful for us.
So thanks, Pam. So this is a system of 8 or 9, maybe 9 sites, which go from large to small, I assume.
Yes.
How have you managed to bridge that gap of making some of these things work, not just in the big fancy academic site, but in the smaller, less resourced site?
Well, I think it's been interesting because the smaller sites have actually been, really anxious to adopt. You kind of, okay, this is a system protocol, and we have some leadership that's coming in and helping us develop this or helping us with the education. So it's been a little bit easier getting those on board because of the leadership support that we've had with the processes.
Yeah, well, that might be a message for smaller centers everywhere, that giving people a little bit of an opportunity to catch up and do the kind of stuff that they're wanting to do, it is often very well received. Ula, what would you like to add? And in particular, I notice, Chris Carpenter in Washington University has a very important question, and I suspect it grows out of a little of his personal feelings of, what do you do when you don't have a team? Like, what do you do when you're one person? And I notice Lauren also had some comments there, but Ula, can you address that?
Yeah, so I would say, I think it's always hard when you're the first one, and often we start off as the team of one, but it's really a matter of, I think Pam and I spent a lot of time, as she alluded to before, we're both relatively new. We landed, here at Yale during the pandemic, in like the last 2 years. And so it's a lot of learning your system, learning who are the interdisciplinary team that you work with. So you heard, Nida speak to it, Amber, the 2 Ambers speak to it. Who are those people that, you're going to want to work with, whether it be case managers, physical therapy, social workers? You work with a recruit. I was really lucky to recruit Pam. I think if we hadn't brought Pam, she's a champion. She was a leader of these programs down in her hospital. And you thought you either build those partners or you try to align with those partners. The first person I sought out when I got to Yale was who the geriatrician was. You may not always have a geriatrician where you're at, but I sought out the leadership of geriatrics and the clinical operators there. And he and I became allies and partners. And he's now Pam's boss. And we were so, like, the 3 of us work together. And so you just continue to try to find those champions and partners to work with, and you grow that team from 1 to 2 to 3. And then we started to identify who are the leads at the other hospitals that might want to do this with us. And it's exciting because these weekly meetings that Pam described, the system meetings are monthly meetings. And each month we have more and more people joining. I'm very excited because I look on the participants attendees list here, and we see some of our colleagues from our New Haven hospital on the call, and it's their leadership at their own respective hospitals we're all like helping each other with the strategies, like, well, how do we get our own leaders in our own internal hospital to like, listen and share. And so we're just sharing stories, sharing strategies, sharing friendly competition. I think some of the themes you brought up earlier about friendly competition. Hey, look, we're performing and we're doing this really well. And another hospital and be like, oh, we're not doing as well. And that inspires each other to, want to, we can get our numbers up to be like you, or, oh, we couldn't, a month ago they thought they couldn't do it, and then the next month they're doing it and they're doing a great job. So it's really exciting.
Just on the subject, thanks, Ula, on the subject of, finding your team. I think it's important to just stay optimistic that you may not have found the person yet, but there will be somebody. I always think, so I've been in the emergency department at Mount Sinai here in Toronto for 20 years, and I was always the guy who was kind of interested in older people. And then one night, but not much other support around. One night, in the middle of a midnight shift, the medicine junior resident said, "I hear you're interested in old people." I said, "Well, yeah, I am." And he said, "Oh, that's interesting. I just finished a PhD in gerontology at Oxford as a Rhodes Scholar, and I'm interested in old people too." And so, we became partners, and he subsequently became, that his name is Samira Sinha, became the chief of geriatric medicine here, and one of Canada's most prominent geriatricians, particularly during the COVID epidemic, and has helped us really transform care at our hospital, including in the emergency department. So you never know when you're going to stumble over that piece of gold ore. So Chris and everybody else who hasn't found your team yet, keep looking. Got to kiss a lot of frogs before you find the prince.
Oh, I want to add one additional thing to finding those teams, and you definitely have to kiss a lot of frogs. But what I will also say is there are some princes right in your own backyard. And I'll say here at Yale, as an example, we have 8 to 9 EDs. Some of them were already Geri EDs. And I'll give you the great story. Peg Parnowski's wrote that in the chat, but Bridgeport Hospital in our system was already a level 2 GED. Milford Hospital is very close by. It's another one of our EDs. And they basically, it was like a sibling, teaching, like Bridgeport sort of taught Milford how to really get all of their programs up and rolling within a year. And Milford is now applying to be a level 2. So there's like, look for others, try to bring partners that are already there, bring new ones in, but then sometimes you might have some really great leadership already in your system to inspire. And we were like super excited. Milford submitted their level 2 GED application in December.
Thanks, Ula. Yeah, I mean, I don't think any of us want to imply that, oh yeah, this is easy, it's no problem at all, anybody can do it. It's that is not the case, and you're going to fail some of the time, and you're going to saying, yeah, I'm interested in old people in our emergency department, and there is not going to be a chorus cheering back at you. But I mean, perseverance. Thanks, Aaron. Perseverance is a virtue, so that is certainly part of the long game as well. Thanks, Pam and Ula, and to Lauren and Katie at Ohio State University in Columbus, Ohio. You were one of the early adopters of geriatric ED care and became an accredited, level 1 accredited site very early on, one of the first in the nation. And then there have been challenges. Katie, do you want to tell us a little bit about how you've needed to adjust, and then we'll hear from Lauren as well.
Yeah, I'm happy to get us started. Thank you for having us. Similar to some of our colleagues, we're a very large academic medical center. To give you an idea of what we're dealing with, it's 110 bed spaces right now, approximately 2 football fields long because it's Ohio State. We were a level 1 geriatric ED before COVID. We didn't see it coming, much like everybody else on this call, and we failed miserably right away. Just like everyone else, our entire department's focus switched to getting ready for the pandemic and what that was going to bring. We went from fairly high screening rates at greater than 70% for our screens that we want every older adult to get, to less than 10%, to give you an idea of how far we fell. We were lucky in that pretty early on in the summer of 2020, our department restarted everything from QI initiatives to research, and geriatric ED initiatives were right there. I think similar to everyone else, our biggest strength and how we recovered was our team. Our team is huge. Thanks to Lauren building it. I got to take over a geriatric ED that was built and add to that team. We have all of the pieces that everyone has mentioned, but our core team is made up of emergency physicians, our nursing leadership and partners. But as a result of COVID and during that period, we actually brought on bedside nurses, residents, our PCAs and patient techs, and we call them our geriatric advocates. They're on the floor all the time. Lauren and I are wonderful when we're there, but we can't be there all the time. And so they're kind of our boots on the ground. And it was with their input and hard work as well through our constant feedback. We also have weekly meetings that we really made the changes we needed to make to get our screening numbers back up. I mentioned we were down at 10%. We're now at greater than 70%. We'd like to be higher, although that puts us on par with others. The things that I think really a handful of them that made us successful to get our numbers back up, and that's but one example that's easy to grasp because it's hard numbers. We noticed that a big fall off was when we lost our staff nurses and went to travelers, which I think everyone is having happen right now. So our geriatric education is not only for our new staff nurses, but we do it for all of our travel nurses as well. One thing that's come up more recently is float nurses and how we're going to fold that in, because that's another hole we found. We also found our efforts very powerful to re-engage services that either prior to the pandemic already didn't have the bandwidth, and now it would be even worse off. But the call comes from the top to decrease hospital admission. And one example of a way for us that we found to do that was to re-engage palliative care, who initially was coming down for our geriatric patients to try and prevent some admissions. But I've heard from a few of our faculty and residents through text, like, hey, they came to this area and helped us with this, and that may have never happened before. So I think our efforts really have benefited everyone. Some other things that we've done that we've added that I think have made us bounce back successfully is we added a screening indicator to the track board. So not me and Lauren walking around and saying, have you done your geriatric screen? Can this patient have this done? Are they eligible? But it's a kind of constant reminder built into our system that our nurses really wanted and have liked. Related to that, you've heard competition come up. We have leveraged that at Ohio State. So you heard 110 bed spaces. It's huge. We see we have more beds than some EDs see in a day. And so we're split into pods, and the nurses in those pods are very proud of their pod. And when we broke down our screening numbers, not by the whole ED, but set the pods against each other, a little healthy competition went a long way. And with that, we made sure that our resident nurse, PCA champions and advocates were in each of those pods and spread out so the whole ED was getting them. And I'll let Lauren talk a little bit more about our incentive for them, because she was really the leader of that. But the incentive has really encouraged them to meet those numbers. And then I'm also going to go ahead.
Well, just one thing we did talk about earlier was the knowing when to push and when not to push. And I don't know if you or Lauren Southerland are going to talk about that.
Sure. So part of what we've been doing the past year is really looking at implementation science approach. So quality improvement is you get your team together and say, okay, we have a problem here. What should we do? And everyone brainstorms. Then you say, we're going to do, Dawn's idea versus Eula's idea. But implementation science is let's actually study it first and see where the problem was. And some of our problems were we had great administrative support, but no champions, boots on the ground champions. So then we recruited resident champions, more faculty champions, and more bedside nurse champions instead of just our nurse educators. So that people know if George is on, that if they don't do their screens, he's gonna be mad at them. Or he'll snipe screens for them because you get prizes for the more number of screens. So that was one thing, is thinking about champions not as as the people working the most shifts and getting night shift and day shift. So we saw some things where day shift was upset because like, well, why should I do them? They were here all night and the night shift didn't do it, and then it falls on me. And to make it more of a, hey, we're all a team here. We know this happens. Sometimes night shifts get crazy. Sometimes day shifts get crazy. The looking at the different areas, if you have a large ED, different areas can function like little tiny countries or civilizations. You know, what happens in your triage or fast track area is not the same. We have an oncology area, an observation unit area, different areas. And so we had high performing versus lower performing. We were able to compare and contrast and see what was going on. And then instead of making up what people wanted, we asked the staff, what would inspire you to do this? I can't give you better pay. I can't stop mandatory overtime. I can't stop people leaving to be paid 3 times as much to be a travel nurse somewhere else. What would help you? And so they've chosen a couple of different things. One was lightsabers for our geriatric ED initiative program called GEDI. The latest thing, this is actually interstate competition, but Cleveland Clinic had white noise machines that play the sparkle lights, like the solar system lights in white noise. So they wanted those because Cleveland Clinic had it. And the last thing was Bravo points, which is our own internal like credit card point system that nurses and faculty can get.
I think it's also important, and this is what Dom was alluding to, which we talked a lot about our pushes, but we have actually kind of stepped back and put the brakes on at times. Take right now, for example, everybody either has COVID or their kid has COVID or their aunt or mother or father has COVID. And then they come to the hospital and it's COVID. So going back to what Nida said, nobody wants to hear about COVID, but we also had times where they had no bandwidth for anything else. And if you went down and said, you know, you have that big ugly stop sign, you didn't do your geriatric screens, Lauren had someone cry, just burst into tears because they just had no, like they were trying their best to do exactly what was in front of them and they couldn't do any more. And I think that's really important to realize when that is, because if you don't stop and realize when your team is at a breaking point and take care of the team, you're not going to be able to move forward. They're just going to put their blinders on and not listen. And so I think part of our strength has been as a team is kind of with all of our boots on the ground and our experience when we work, figuring out when that is. And right now, we're not pushing that hard. Our numbers are actually maintaining themselves this time. But right now, our staff doesn't have the bandwidth. I don't know if Lauren has any more crying stories, but it's true. And you need to know when that is and when to step back.
Lauren often makes me cry, so I can fully understand that, nurse.
We met the first week of January because we meet every other week for our Jedi team and just looked at you like, we're just going to stop for this month. January, just toss January. It's all terrible.
So you said you had a whole suite of screens and things. And as you're reintroducing things, how have you decided what you're going to prioritize? Katie?
So everything was always running in the background, and it still is. It's just a matter of what we're going to push on and when. So when we're coming back from COVID initially, we looked across what we had, and we think it's really important, for example, to screen for delirium and elder abuse and falls. And these are things that affect every geriatric patient, but maybe even more important in COVID. I think most people on this call are probably familiar with the recent paper by some of our wonderful colleagues that showed delirium is a presenting symptom of COVID. So we really hit some of our screens hard because we thought it was important in COVID, but also in general. And that way we could at least focus on those few things way back when we were starting in summer of 2020. And then for the most part, we were able to fold everything else back in and kind of push everything. But, you know, there's moments like this right now with Omicron where we're falling back on those specific screens and the things that the key pillars that we think will support everything else when we come back.
Katie, thanks for that. I just noticed there's an interesting question. Did you do more training for your staff regarding delirium other than just screening for it?
No, we used to have a 2-hour nurse training session where when they were onboarded, they would get these 2 hours of GEDC education, and we stopped it. And now as the travelers, as the floats are coming down, our nurse educators try to do just a quick bedside teaching that's about 15 minutes because we just have, the staff turnover is terrible.
So I think that's a good example of, pick your battles, know what the limits are, where the front line is, and you can't go beyond the front line. At the moment, the front line will change in the future. Thanks for the question, Lori. I wish everybody involved in the chat could also be on this webinar because there's lots of interesting stuff happening in there. Kevin Bice, I can't help noticing you've been very active in the chat, and you are somebody who's on the panelist call. As we're starting to wrap up, any comments that you thought were particularly appropriate? Masked leader.
No, thank you so much. Yeah, exactly. In the hospital today. Just want to say, I think it was fantastic. I mean, we've heard from smaller, more rural setting EDs. We've heard from really big academic centers. We've heard from community sites attached to academic centers. And I think that it's hard to get stuff done right now, but my goodness, if there are adults, it is now, and people know that. And so I guess two themes that I've kind of picked up on is one, there's two slightly different approaches. The net result is kind of the same, but one of the themes that's come through is how can the system help the frontline staff make their job even easier or a little better? So it's one thing to be like, you all should do this. It's another thing to be like, we've built this into the system, or we've got you some more care management resources, or we're able to deploy this. And the GEDA and the accreditation can help get frontline staff, not as just one more thing to do, but as something that perhaps there's some help to get done can help. And finally, at least in the system I work in, if there ever was a time that the argument of this program can help us get people discharged from the ED to home as opposed to waiting in the hallway for a bed upstairs, I think that argument has a lot of resonance right now and might help you build that team that a lot of us are missing. But mostly I'm just inspired by what I've heard. So thank you.
Yeah, I think there's a lot of inspiration here. Thanks a lot, Kevin. So Lorraine, can you take us back to the slides as we've got just a few minutes left together. We have summarized the main points from each of our speakers here. I won't go through all these in details. One of the clear themes for me that stood out was stories and statistics that harness the power of telling a story about an individual patient. It's often much more powerful to change makers than the best randomized controlled trial study. Statistics, keeping track of what you're doing, and communication with the folks who are actually doing the work, and healthy competition leading to incentivization. So I've just blazed through those various teaching main points, mostly as a taster to get you to come back to the GEDC website. You can access this slide deck as of tomorrow, and it might help you remember some of these main points. Eula, were there any essential questions came up out of the chat, bearing in mind we've got 3 minutes left?
No essential ones, I think, except for if you didn't hear, like if you had I think John Schumacher actually had a great one. Were there any other interesting hacks that maybe some of the participants might have had in terms of how they dealt with COVID? If you didn't hear it discussed by the 4 systems presented today, please type it in the chat. I will say, as always, we have a very diverse group of participants, many countries and continents. Representatives from Australia, Europe with Switzerland, South America with Brazil, several Canadian provinces, US, again, all the way east in like the Boston, all the way to the West Coast, northern, southern in California. We had many hospitals actually from the Indian Health Services on today, which is really exciting. So rural hospitals are also trying to move forward with geriatric ED care programs, even during the period of COVID. And so I just really wanted to highlight that, a diverse group. And I think one thing that we probably heard today is like, you might be small, but some of the small hospitals are mighty in their ability to implement these programs.
Good. Next slide, please. just wanting to let you know about our next webinar, which will be, I think, 7 weeks from today on March 14th. We'll be looking specifically at accreditation and how accreditation can be helpful at creating a geriatric emergency department. That will, Dr. Kevin Bice, who is just on the line here, is the chair of the Board of Governors of the Accreditation Project, and Nicole runs the program. I would also direct you to the book that you see, which has me and a nice patient who's actually a friend of mine. John Schumacher and I, has John already posted it in, we have, as of February 2nd, the book will be released. It's called Creating a Geriatric Emergency Department. It can be pre-ordered or ordered from Cambridge University Press. As of now, one more slide, please. That's how to reach us. And final slide. Before I thank our generous sponsors, I do want to really thank our presenters today. It was absolutely awesome panel. And I must point out that aside from the single outlier of Aaron Malsch, I hope you all notice that these are 8 fabulous women leaders in our field, rocking geriatric emergency department from coast to coast and from city to town. So it was really wonderful having all of you. Thanks so much. I mean, we all know how hard it is to find a spare hour these days. It was really generous of all of you guys, all of you girls, to show up on the call. We really appreciate it. And then we wouldn't be able to do this work without our sponsors, John A. Hartford Foundation, the West Health Institute. We appreciate you guys a lot too. A reminder, all these resources will be available on our website as of tomorrow or the next day. That is the slides, a recording of the video, and the chat, which I think is a little booklet on its own in Geriatric ED Change. So with that, thanks once again to everybody who showed up for the webinar as well, and I'll say goodbye until next time. Thanks a lot for being here. Bye-bye.
Thank you.